Picture this. You got an elite 21-year-old Olympic powerlifter, right? Like someone at the absolute peak of human conditioning.
Right, the pinnacle of physical strength.
Exactly. So they step up to the bar, they brace their core, and they execute this flawless, massive squat. But if you actually look at the medical data on stress urinary incontinence, or SUI, that specific athlete in that exact moment is, well, they represent one of the demographics most severely impacted by this today.
It's actually wild when you look at the numbers.
It really is. We're looking at young, melliferous, rhythmic gymnasts, so athletes who have never given birth, collegiate volleyball players, competitive weightlifters, and they're experiencing prevalence rates that just completely shatter those traditional stereotypes. You know, the heavily marketed idea that pelvic floor failure is just something that happens to older women or postpartum mothers.
Yeah, that sports medicine data totally upends the assumption that SUI is, strictly a byproduct of age or trauma. It really forces us to look at the pelvic floor through a purely biomechanical lens.
Which makes sense, right? Yeah. Because of the forces involved.
Completely. When a powerlifter braces, the diaphragm acts like a piston. It drives all the viscera downward and creates this massive intra-abdominal pressure. And, well, if the upward counterforce of the pelvic floor muscles cannot mathematically match that downward pressure vector, the urethral sphincter just yields.
The mechanical seal just breaks.
Right, it breaks and leakage happens. It's just physics.
Which brings us to the core mission for this deep dive. Because if we're treating this as a strict biomechanical equation, then obviously the muscle needs to be trained.
Right, you have to build up that counterforce.
But the amount of conflicting advice floating around regarding that training is just staggering. So we are cutting through the noise today to answer one highly specific, critical question for you. Exactly how long and how intensely do you actually need to perform targeted pelvic floor muscle training before you should, throw in the towel and consider an invasive surgical procedure?
And that is arguably the most critical pivot point in all of urological care. Navigating it requires looking really closely at the consensus among the major medical bodies.
Which we've got right here.
Yeah, our clinical stack today relies heavily on the 2019 UNC guidelines, the 2023 AUA and SUFU guidelines, and the European Association of Urology protocols.
A lot of heavy hitters.
Oh, definitely. And we are cross-referencing those international standards with large-scale randomized controlled trials and systemic reviews. We want to see what happens when you pit conservative management directly against surgical intervention.
Okay, let's unpack this. Before we get into the exact mechanics of the protocols, we really have to establish the biological reality that drives this clinical timeline. Because, if you present to a urologist today with SUI, regardless of whether you're an Olympic athlete or a postpartum mother, they're going to hand you a very rigid, non-negotiable prescription for time.
Universally. The standard mandates a strict minimum of 3 months or 12 weeks of intensive pelvic floor muscle training as the absolute first-line therapy.
12 weeks. No shortcuts.
None. Surgeons will generally refuse to even operate until that 12-week threshold is crossed. And to understand why that specific duration is hard-coded into the guidelines, we have to kind of strip away the mystique of the pelvic floor and look at its cellular composition.
Right, because at the end of the day, the levator ani and the urethral sphincter, they're just skeletal muscles. They're a striated tissue.
Exactly. They do not operate on magic.
They obey the exact same physiological laws as your biceps, your hamstrings, or your quadriceps.
What's fascinating here is how that cellular reality dictates the timeline of recovery. The American College of Sports Medicine outlines very distinct phases of adaptation when you load any skeletal muscle.
Like when you start lifting weights.
Right. During the first 8 weeks of literally any heavy resistance training program, the actual structural changes to the muscle fibers are virtually non-existent.
Wait, non-existent?
Pretty much. You are not building new myofibrils. You are not increasing the cross-sectional area of the tissue.
So, wait, all the strength gains someone feels in those first 2 months, that's entirely neurological. Like the brain is just carving a more efficient pathway to the muscle.
Precisely. It is a process called rate coding and motor unit synchronization. Your nervous system is basically learning how to recruit a higher percentage of the existing muscle fibers and, crucially, fire them all simultaneously.
Wow. Okay.
It's a software update. The brain gets vastly better at utilizing the hardware it already has, but the hardware itself hasn't grown a single millimeter.
That's crazy. So it's literally like a New Year's resolution gym goer expecting to look like a bodybuilder by February 1st.
Right.
It's biologically impossible.
Yeah.
True structural muscle hypertrophy, like actually building the muscle volume and mass to bulk up that pelvic floor. That just takes time. The ACSM principles in our sources state that real hypertrophy requires 15 to 20 weeks of consistent, heavy resistance training.
Which really highlights the tragedy of patients giving up too early.
Yeah, that makes sense.
I mean, if someone performs targeted training for 6 weeks, experiences a slight plateau, and then stops because they don't feel entirely cured yet, they are abandoning the protocol before the muscle has even had the physiological opportunity to physically grow.
They're quitting during the software update.
Exactly, well before the hardware upgrade even begins.
I have to challenge the guidelines here, though. I mean, if the American College of Sports Medicine definitively states that structural hypertrophy takes 15 to 20 weeks, why do NICE and the European Association of Urology set the evaluation threshold at 12 weeks?
It's a good question.
Right. Why not force the timeline to, say, 5 months to ensure maximum cellular growth before letting a surgeon anywhere near the patient?
Well, the 12-week mark serves as a calculated clinical checkpoint rather than the absolute finish line for muscle growth.
Okay, a checkpoint.
Yeah. At 3 months, the patient has fully maximized those neural adaptations we talked about, and they're just beginning to cross the threshold into early structural hypertrophy. And from a clinical perspective, that specific combination of peak neural drive and initial tissue growth is usually sufficient to yield a statistically significant drop in symptoms.
Like how much of a drop?
On average, you're looking at a reduction of at least 1 leakage episode per day.
Okay, so the 12-week mark isn't really about achieving a flawless 100% cure. It's about proving the concept. It's enough time to determine if the muscle is physically capable of responding to the load at all.
Precisely. If a patient hits the 12-week mark with absolutely zero reduction in leakage, it signals a much deeper pathology.
Like what?
Well, the nerve damage from a pelvic trauma might be too severe, or the fascial tearing might be too profound for conservative training to ever overcome. And in those cases, pivoting to surgery makes complete sense.
You don't want to waste their time.
Right. But if there is measurable improvement at 12 weeks, the guidelines heavily advocate pushing the training up to 24 weeks.
Because the hypertrophic benefits will just exponentially increase as the tissue continues to bulk up. Okay, so establishing that 3 to 6 month timeline brings us to a massive behavioral pitfall. Because honestly, spending 12 weeks doing the wrong exercises is arguably worse than doing nothing at all.
Oh, absolutely.
The guidelines are really adamant that intensive training requires a specific biomechanical load. Doing a casual little squeeze while you're sitting at a red light is not going to trigger structural hypertrophy.
Not even close. Skeletal muscle requires progressive overload to grow. The regimens outlined in the clinical data are actually really demanding.
What does a standard intensive protocol look like?
It requires 8 to 12 maximal contractions.
Maximal, so like 100% effort.
Yes, meaning the patient is pulling up and in with as much force as physiologically possible and holding each contraction for 6 to 8 seconds.
Oh wow, that's a long hold for a maximal squeeze.
It is. And that entire exhaustive set must be repeated at least 3 times a day.
And the composition of the levator ani makes it even more complex, right? Because our sources say it's a mix of type 1 slow twitch fibers for endurance and postural support, and then type 2 fast twitch fibers for sudden impacts.
Exactly. Which is why the protocols cannot just focus on those sustained endurance holds. The regimen has to escalate.
How so?
Some specialized programs demand up to 45 maximum contractions daily, and they intentionally weave in rapid flicks.
Flex.
Yeah, rapid, sudden, violent contractions designed specifically to fatigue and build those type 2 fast twitch fibers.
Okay, that makes perfect sense biomechanically, because if a pressure wave from a sneeze is traveling down through your abdomen, you do not have 8 seconds to slowly recruit your slow twitch fibers.
No, you'd be way too late.
Right, you need an instantaneous fast twitch reaction to basically clamp the urethra shut.
And the sources refer to the conscious mastering of this reaction as the knack.
The knack, I like that.
It's very catchy. It basically involves the intentional preemptive coordination of the pelvic floor muscles just before and during a spike in intra-abdominal pressure.
So timing is everything.
Yes. When a patient feels a cough coming on or they prepare to lift a heavy barbell, they consciously brace the pelvic floor upward. This pins the urethra against the pubic bone right before that downward pressure wave hits.
Wow.
And over a 12-week intensive period, the goal is to drill this conscious, voluntary contraction so thoroughly that it just converts into an automatic subconscious reflex.
But there is a massive caveat to all of this in the guidelines, right? Both NICE and the EAU issue a grade A. Strong recommendation that this intensive training must be supervised by a specialized healthcare professional.
It has to be.
Like handing someone a pamphlet and telling them to do this solo in their living room has a disastrously high failure rate.
It really does. And the reason is that the pelvic floor is entirely internal, which creates this severe proprioceptive blind spot for most people.
You can't see it.
Right. You cannot look in a mirror and verify your form the way you can with a bicep curl. The data actually shows that up to a third of patients, when they are just given verbal instructions to contract to their pelvic floor, will instinctively bear down.
Oh, no.
Yeah, they push outward, actively increasing the intra-abdominal pressure.
Which is the exact mechanism that causes the leakage in the first place.
Exactly. They are essentially training the muscle to fail.
That's terrifying.
That's why direct supervision by a specialized physiotherapist is so critical. It eliminates that risk entirely. The clinician performs a digital assessment to physically verify the contraction vector.
So they can feel if it's right.
Yes, they ensure the patient is genuinely pulling up and forward to cope with the urethra, rather than just compensating by, squeezing their gluteal muscles or holding their breath.
Right. Well, since isolating the muscle is so incredibly difficult, I actually went looking through the sources for technological solutions. Because the market is flooded with biofeedback sensors, vaginal cones weighed at anywhere from 20 to 100 grams, surface electrical stimulation devices. I mean, do patients need to invest in a whole clinical suite of hardware to get through these 12 weeks successfully?
The guidelines are remarkably unambiguous about this.
Yeah.
They explicitly advise against relying on hardware as a primary solution.
Really?
Yes, they strictly state, do not use surface electrical stimulation alone for the treatment of SUI.
So just applying skin electrodes to force a contraction doesn't yield better long-term hypertrophy?
It completely fails to build the vital neural pathways we discussed earlier, the brain-muscle connection.
The software update.
Exactly. Furthermore, the data on biofeedback, where, a vaginal or anal sensor displays the contraction strength on a digital screen, is incredibly humbling.
Humbling how?
Well, the Hagen trial, which is this massive, multi-center, randomized controlled trial involving 600 women, investigated this exact premise. The researchers compared one group doing supervised PFMT with electromyographic biofeedback against a control group doing supervised PFMT without any visual sensor data.
Let me guess. Seeing a digital line go up on a screen didn't magically change the cellular hypertrophy of the muscle.
You nailed it. At the conclusion of the Hagen trial, there was zero statistically significant additional benefit to the biofeedback.
Zero. Wow.
Both groups improved equally. If a specialized physiotherapist is already providing accurate tactile and verbal cueing, adding an expensive digital sensor to the mix simply does not accelerate the physiological healing process.
It's just bells and whistles.
Basically. Biofeedback is relegated to an optional adjunct. It might be useful for a patient who has absolute zero baseline proprioception, but it is far from a magic bullet.
Here's where it gets really interesting, though. While physical hardware, like those electromyographic sensors and surface electrodes, totally failed to move the needle in the clinical trials, software technology produced a completely different outcome, specifically smartphone applications designed for PFMT.
The success of smartphone applications highlights a really brilliant shift in clinical strategy.
How so?
It moves the focus away from trying to artificially stimulate the muscle, and it targets the actual root cause of conservative treatment failure: human behavior.
Yeah, the psychological barrier of working out an invisible muscle for 3 months is just immense. I mean, there is no instant gratification. You don't get a pump. You don't see your muscles looking bigger in the mirror.
And the long-term adherence rates really reflect that psychological friction. Studies tracking patients over a 10-year period reveal that only 15 to 28% of women actually continue maintaining their pelvic floor exercises.
That is so low.
The vast majority just get bored. They become frustrated by the slow biological timeline, and they abandon the protocol entirely.
Which is exactly where the behavioral reinforcement of an app steps in.
Right.
Our sources highlight this fascinating randomized trial comparing a standard physical protocol against the exact same protocol, but guided by a dedicated mobile app. And the app featured animations, a robust recording system, push notification reminders, all that stuff.
And the results were striking.
Yeah. At the 8-week mark, which is right in the middle of that frustrating software update phase where patients usually quit, the app group maintained a 66% adherence rate compared to just 52% in the control group.
And by the crucial 12-week evaluation threshold, the gap widened even further. The app group held strong at a 59.1% adherence rate, while the control group just plummeted to 37.8%.
If we connect this to the bigger picture, the app isn't actually changing the biomechanics of the pelvic floor, is it?
No, not at all.
It isn't making the fast twitch fibers contract harder. It's just acting as this relentless digital coach. It's gamifying the process just enough to ensure the patient actually completes the agonizing daily workload required to achieve hypertrophy.
Exactly. It bridges the behavioral gap between the patient's initial motivation and the delayed biological reward of the muscle actually growing.
Okay, so let's explore the inevitable clinical reality here. A patient downloads the app. They work closely with a specialized physiotherapist. They diligently execute 45 maximal contractions a day, mastering the knack for 12 to 24 grueling weeks.
They do everything right.
Exactly. The neural drive is maxed out, the structural hypertrophy has peaked, but the structural damage to the pelvic floor is simply too severe, and they are still experiencing massive leakage during a heavy squat or a violent cough.
It happens.
Where does a patient go next in the algorithmic pathway?
Well, this is the critical crossroads where the guidelines pivot from conservative management to invasive surgical intervention. If the physiological limits of the muscle have been reached and the symptoms remain unacceptable, the focus shifts. We move from strengthening the dynamic support system to artificially reinforcing the mechanical seal.
I was looking at the intermediate steps in the algorithm before you get to major surgery, specifically urethral bulking agents. The clinician injects biomaterials, like specialized hydrogels or silicones, directly into the submucosal tissues surrounding the urethra.
Right.
But I really struggle to understand how injecting a static gel solves a dynamic muscle failure. How does that physically halt the massive pressure wave of a cough?
It's a great question. Bulking agents operate on the principle of coaptation.
Trocation.
Yeah. If you imagine a door in a drafty house where the frame has warped, the door no longer sits flush against the jamb, right? It allows air to leak through. Injecting a bulking agent is the physiological equivalent of installing thick weather stripping.
Okay.
It plumps up the internal walls of the urethra so that they meet perfectly in the center. Even if the surrounding levator ani muscle is way too weak to provide strong dynamic compression, that artificial bulk creates a tighter resting seal. It just increases the baseline resistance against downward abdominal pressure.
Okay, I see. But the body's immune system isn't just going to ignore a foreign hydrogel injected into the tissue, is it?
Definitely not. And the immune response is exactly why bulking agents are considered a temporary intermediate step.
So they don't last.
No. Macrophages recognize the biomaterial and they initiate an inflammatory response, gradually breaking down and absorbing the hydrogel or silicone over time. The weather stripping basically degrades.
So they have to do it again.
Yes. Patients frequently require repeat injections after a year or two as the clinical results diminish. It is a minimally invasive outpatient procedure, which is great, but it lacks permanence.
Which pushes the algorithm toward the ultimate gold standard surgical fix.
Yeah?
The mid-urethral synthetic sling.
Exactly. The anatomical logic behind the synthetic sling is really brilliant in its simplicity. Surgeons navigate either through the retropubic space behind the pubic bone or via the transobturator route through the groin.
Ouch.
Yeah. And they place a narrow strip of synthetic mesh directly under the mid-urethra.
So it essentially acts as a permanent artificial backstop. Like when the patient coughs, the intra-abdominal pressure pushes the urethra downward. But instead of yielding, the urethra violently collides with this rigid mesh hammock,
Which physically kinks the tube shut and stops the leak instantly.
The clinical data on this mechanism is staggering, honestly. Mid-urethral slings boast a massive 85 to 90% short-term objective cure rate.
It's incredibly effective.
And even when researchers track patients out to 10 or 12 years post-surgery, the long-term cure rate stabilizes at an impressive 69%. It is a highly durable, anatomically sound solution.
It really is.
But I have to play devil's advocate here and challenge the entire premise of the guidelines.
Okay, let's hear it.
If we know from the systemic reviews that the mid-urethral sling has an 85 to 90% cure rate, and we know that 12 weeks of agonizing PFMT only definitively cures about 1 in 3 women, why do the guidelines aggressively force patients to suffer through 3 to 6 months of daily physical therapy? If the surgical hammock works that efficiently, why not just offer the sling on day 1 and save the patient half a year of frustration?
It's a fair question, but it ultimately comes down to the fundamental medical principle of balancing risk against objective outcomes. Surgery crosses a biological Rubicon that simply cannot be uncrossed.
Meaning you can't undo it.
Exactly. While mid-urethral slings are incredibly safe and effective for the vast majority of patients, they carry the inherent risks of anesthesia and, much more importantly, rare but devastating mesh-specific complications.
You are talking about vaginal mesh erosion.
Yes, the pathology of mesh erosion is severe. The synthetic material can sometimes trigger a chronic, hostile inflammatory response. Instead of seamlessly integrating into the body, the mesh degrades the native vaginal epithelium. It eventually cuts through the tissue entirely.
Oh, wow. That sounds horrific.
It leads to chronic, debilitating pelvic pain, severe dyspareunia, and it occasionally requires highly complex reconstructive surgeries just to extract the integrated mesh from the bladder or the urethral wall.
Meanwhile, the risk profile of completing 12 weeks of targeted Kegels is,
Yeah.
well, non-existent.
Exactly. Pelvic floor muscle training carries a literal 0% rate of severe adverse events. It is entirely non-destructive. Furthermore, judging PFMT solely by its 33% absolute cure rate totally ignores the subjective reality of the patients.
How so?
Well, while it is true that only 1 in 3 women achieves 100% dryness, an additional 40 to 60% achieve such profound, life-altering improvements in their daily symptoms that they happily choose to cancel their surgical consultations.
Ah. So they might still experience a few drops of leakage if they attempt a 300-pound deadlift, but they can comfortably run a 5K, jump on a trampoline, and sneeze without fear.
Right.
And to them, that vast improvement in quality of life is an absolute victory.
It is. The mandated 12 to 24 weeks of physical therapy is just a brilliant investment in risk mitigation. If a patient can achieve an acceptable functional quality of life with zero risk of synthetic mesh erosion, that time is incredibly well spent.
So what does this all mean? If you, or someone you care about, is dealing with stress urinary incontinence, you now possess the exact clinical blueprint. You understand the biological laws governing the tissue. The scientifically backed timeline requires a bare minimum of 12 weeks and optimally up to 6 months of supervised, highly intensive, targeted muscle training.
And you have to put in the real work.
Exactly. You know that casual squeezing will not trigger structural hypertrophy, and you know that leveraging an app is clinically proven to keep you on track during that grueling software update phase. You are armed with the knowledge to advocate for yourself, ensuring no clinician rushes you into a surgical suite without an adequate trial of conservative therapy. But simultaneously, if you put in the grueling work for 6 months and the structural damage is simply too great, you can step forward, knowing you have powerful, highly effective surgical options waiting to catch you.
The clinical clarity really empowers the patient to take absolute control of their timeline. But, looking at the biomechanics of this entire process, this raises an important question.
What's that?
Well, we have spent this entire deep dive talking about the pelvic floor as an isolated skeletal muscle that requires a dedicated 15-minute workout 3 times a day.
Right, treating it like a highly localized bicep curl.
Exactly. But if the levator ani operates in tandem with our core and our postural back muscles, perhaps the future of SUI prevention shouldn't revolve around isolated Kegel time. If those 21-year-old Olympic powerlifters are teaching the medical community anything, it is that the pelvic floor's primary job is managing violent, dynamic, real-world forces. So perhaps the ultimate goal isn't just surviving a temporary 12-week clinical program. Perhaps the future is about seamlessly integrating pelvic floor engagement into every single functional movement we execute,
I love that.
transforming the simple acts of walking, lifting groceries, and breathing into a permanent, lifelong training session.
Upgrading from a localized software patch to an entirely new whole-body operating system. Something to deeply consider the next time you brace yourself to pick up a heavy box.